In terms of treatment of pain, we'll first start with non-narcotic analgesics and NSAIDs, non-steroidal anti-inflammatory drugs. Now, first some background information. What's pain? Pain is an unpleasant sensation associated with suffering. The purpose of pain is really to warn you that there's something wrong. Right? It's a warning. It's a protective reflex for self-preservation. It informs you that something's wrong. Now, there are two components to pain. There's what's called pain perception and pain reaction. The pain perception is the process by which a harmful stimulus causes activation of nociceptors or noxiceptors. I usually spell it noxiceptors, but it's actually very common for other books to refer to them as nociceptors. I'm sure you've run into that. A nociceptor or a noxiceptor is a name for a pain sensory neuron, a sensory neuron that mediates the modality of pain. So how does this work? When there is a noxious stimulus, and our first thought is, what does that mean? Noxious means harmful. When there is a harmful stimulus, anything that harms the body, anything that injures the body. So anything that injures the body, you cut yourself, you burn yourself, you have an infection, it injures cells. The injured cells release these chemical mediators that we've been reviewing, including prostaglandins and others. And prostaglandins and kinins specifically activate or stimulate pain sensory neurons. And these pain sensory neurons send signals up to the brain. We wrote, as far as transmission of noxiceptor information, that pain is both a sensation and an emotion. It is both. Like, what do I mean by that? When you see the color blue, it's a sensation. You're seeing something. We do not all necessarily feel emotionally the same way about the color blue. Some of us like blue, some of us prefer red, some of us like green. But in terms of pain, not only are we being made informed of a sensation, but it creates an emotion in us that all normal people try to avoid. Now, there are two neural pathways for this pain, these pain signals. And on the next page, there's what's known as a sensory discriminative pain pathway and a motivational affective pain pathway. These two pain pathways are related to two facets of pain. I'm going to put this all together momentarily. Let's say that you were chopping vegetables in the kitchen with a knife, and the knife slipped, and you cut your finger. So the first thing when you cut your finger is you feel a sharp, ouch! Right? That is a sharp, localized pain. That's what you first feel. And then a few moments later, this happens first, and then a few moments later, you get this dull, aching pain that starts to be accompanied by emotions. So the first pain, the ouch, that wasn't yet emotional. It was just it hurt. And then you start to get this dull, aching pain that's related to emotion. Now, we can help clarify the point I'm really trying to make by looking at page M17 first. We'll look at M17. On M17, so here's our famous trigeminal nerve, and inside the trigeminal nerve are all kinds of sensory neurons, including pain sensory neurons. And some of them are coming from all over the face, including the teeth. And they're sending signals into the brain. But on the next page, M18, they're actually on the lower left of M18, two types of pain sensory neurons. What are known as A delta fast pain sensory neurons and type C, slow pain. So these are two types of pain sensory neurons, two types of noxiceptors. Notice that I depicted the A delta as myelinated and the type C as unmyelinated. So that's why the ones that are myelinated, that's called fast pain, and this is called slow pain. Now, let's look at the fast pain first. The myelinated fast pain neurons come into the central nervous system, they synapse, and the signals then travel through what's called the neospinothalamic pathway. So this is a bundle of myelinated neurons that is sending signals that originated in those myelinated fast pain neurons. And where's it going? It goes to the thalamus of the brain. This area is called the thalamus. It's labeled right here. All right, so this is the thalamus. And from the thalamus, the signals are then relayed from the thalamus up to the cerebral cortex. So, here's the point for fast pain. For fast pain, this was when you cut yourself, there was injury to your finger or your tooth, whatever it is. It activated the fast pain sensory neurons, the myelinated ones. The signals are transmitted up to the thalamus, and from the thalamus up to the cerebral cortex, and you go, ouch! It's my finger. Now, traveling at a slower speed are these unmyelinated pain sensory neurons. And these slower signals are then going up what's called the paleospinothalamic pathway. So if the fast pain is going along the neospinothalamic, and they synapse in the thalamus, the slow pain is going through the paleospinothalamic. Paleo means ancient. And these are synapsing in the thalamus and the limbic system. Now, what do we know about the limbic system? Emotions. So this goes up here to the thalamus, and then from the thalamus right here to the limbic system. And when this signal reaches the limbic system, this causes the dull throbbing, oh, the emotional pain. Do you see the two facets of this? Now, why have I bothered to review all this kind of, quote, neurophysiology? Because narcotic pain relievers primarily block the slow pain. It's emotional. So narcotic drugs don't really block the fast pain. They primarily block the slow pain. All right? So you can still be under the influence of a narcotic drug, let's say codeine or Vicodin, and you can still, if you prick a finger, you know, we put a needle into your finger, you'll still go, ouch! But what you don't feel is that throbbing, that's emotional, ugh. That has been taken away by the narcotic to a large extent. It always depends upon dose. So there's two facets to pain. So now that I've kind of tried to convey that, let's go back to M2. So what do we call these two pathways? So this is the fast pathway, fast pain, slow pain. The fast pain is the sensory discriminative pathway. It's fast, it's sharp, it involves the neospinothalamic tract, and the signals go first to the thalamus and then to the cerebral cortex. What about the slow pain? This is called the motivational affective pain pathway. I'm not asking you to know all that jargon. This is the slow, dull, diffuse throbbing pain. This is the emotional reaction. This involves the paleospinothalamic tract. These signals go to the limbic system. It's believed that the perception of pain is similar in all people. In other words, if we put a little electric stimulator on your finger, and we started giving you electric shocks on your finger, and we asked you at what voltage do you start to feel pain, we would all feel the pain at approximately the same voltage. So our perception of pain is very similar, it's believed. What differs in people is the reaction. So in other words, we might all start to say, yeah, I'm feeling the pain now at that voltage. So am I. Does it bother you? For some of us, we'd say, no, I'm okay. For the others, they'd say, that's it, turn it off. So how we react or respond to the same pain differs. And not only does it differ in individuals, it differs within each of us between one day and another day. We all have good days and bad days. And on a bad day, we don't tolerate pain as much as on a good day. Right? So some of the factors that affect your reaction to pain and how much you'll tolerate is, are you well rested? If you're well rested, we can tolerate more pain. If you didn't sleep last night, you just don't have the, you react to pain very intensely. This is the reaction, and that varies in people. On page M3, so the reaction to pain includes the startle reaction. And one of the things that they probably trained you is that if you're going to do anything that might hurt the patient, it's probably better to tell them, this may hurt a drop. You don't have to exaggerate it or be too detailed, but it's probably better to say, this may hurt a little. Then they ready themselves, and then when it hurts, they trust you because you told them. If you just make something hurt, then they feel you don't know that it's causing them to hurt, and then they don't trust you as much. So, of course, if it's done all of a sudden and they weren't informed ahead of time this might hurt, they're startled. And that startle reflex is going to also include withdrawal, where they're going to turn their head away from you, right? Because they don't want to be near anything that's causing pain. And the reaction also includes, the emotional response includes pain and vocalizing, yelling. There are autonomic changes. When people are experiencing pain, it causes pupils to dilate, perspiring, tachycardia, changes in blood pressure. These are usually sympathetic stress, not always. Sometimes there's some parasympathetic effects, but mostly sympathetic, because this is stress. It can trigger memories of past experiences in the dental office. So all of a sudden they start to remember, yes, this happened to me last time. I was in the dental office as well. And they start exhibiting avoidance behavior, wincing, wringing of the hands, tapping of the feet, rubbing the injured areas. You know, a wince is a grimace and so on, and like that. The pain reaction threshold, we said, differs between people and even varies in an individual from day to day. What are the factors that affect the reaction to pain? Pain reaction. So it's affected by your emotional state. Is it a good day or a bad day? Are you well rested or not? Now, what I'm going to say about age and gender, this is what the books say, but I've been teaching now for so many years that I've been informed by my students that this is no longer true. They used to say that older people tolerated pain better than younger people, that they tended not to react as quickly. But I've been told that there are plenty of older people who don't tolerate pain well at all. Used to be thought that if you were older, you kind of been through all kinds of pain in your life and you tolerated it better. They used to say that men tolerated pain better than women, but I've been told over and over now by students that even though the books will still say that, the women tolerate the pain better than the men. It used to be that, you know, guys were brought up, big boys don't cry. So anyhow, those classic stereotypes of gender and age and gender differences seem to have broken down. The other cultural aspects, there still may be some validity among the cultural differences. they would say that people, for example, of Mediterranean European ancestry, meaning people who were Greek and Italian and Turkish and Jewish and so on from the Mediterranean, were more expressive in emoting and so on. And those from Scandinavia, where it's really cold, they don't tend to express themselves as much and react as much. So they used to talk about these cultural differences. As I pointed out, patients dislike surprises, and you want to gain their confidence. Other factors that affect the reaction to pain is past experiences, and most drugs actually make the person more reactive to pain. And what I mean by that is alcohol. A lot of patients figure, gee, you know, I don't like going to the dentist, I'll have myself a drink before I go. Alcohol is not a pain reliever. Alcohol takes away your inhibitions, and they're more likely to react more intensely to pain, not less to pain. All right? It's not like taking a pain reliever. Alcohol or marijuana and other things takes away inhibition, and they'll tend to react more intensely to pain. On the next page, this is more for the purposes of nursing, but when you try to evaluate pain, among the questions that are asked is, you know, when you're asking about pain, let's say in the mouth, is the pain sharp or dull? Is it radiating? Is it pulsating? Do you know what might cause it? Where does it hurt? Point to where it hurts. When does the pain occur? Is there anything that brings on the pain? Incidentally, the context that you still ask these questions is like when you have a toothache and you're trying to figure out which tooth it is. And sometimes it's not so easy to know which tooth is actually causing the pain. And so, or you ask, what brings on the pain? Is it hot? Is it cold? Is it something sweet? What brings on the pain? Just trying to isolate what's going on here. What makes the pain worse? What makes the pain better? And so those are classic questions. Now, at the bottom of the page, pain management of pain. So my favorite way of managing pain is remove the cause. If you've got a thorn in your hand and it hurts, remove the thorn. Okay? You've solved the problem. So that's the one way to solve the pain problem, remove the cause. Another is to decrease activation of the pain sensory neurons. Now, the drugs that decrease stimulation, that decrease activation of the pain sensory neurons are aspirin and Tylenol. We'll explain how they work. Another approach is to block conduction of the pain nerve impulses. That's what local anesthetics do. Local anesthetics block the conduction of the nerve impulses along the sensory neurons. Another approach is to depress the reaction to pain. The narcotic pain relievers, narcotic drugs, are acting on the limbic system. They are affecting the emotional center. That's why, because narcotics are affecting the limbic system, people get addicted to it because it makes you feel good. It's affecting the person emotionally. Somebody who's addicted to heroin, they like being on heroin. So it's affecting the emotions. Acupuncture and meditation and biofeedback and hypnosis are believed to be basically alternative ways of affecting that limbic system. Right? The power of suggestion with hypnosis, acupuncture and acupressure is affecting the limbic system, it's believed. Another way to deal with pain is to induce unconsciousness. Take a hammer and hit the person on the head. Or use a general anesthetic. Now, clinical principle. It is impossible to be free of all pain unless you're unconscious. So in other words, even with a narcotic pain reliever, you still feel pain. Vicodin does not eliminate all pain. It reduces it, it doesn't stop it. The only way not to feel pain is to be unconscious. If you're totally unconscious, you don't feel anything. Now, Some terms here. What's the difference between an analgesic, a local anesthetic, and a general anesthetic? Analgesic means to take away pain. Algia means pain. So that decreases the perception of pain without any loss of consciousness. A local anesthetic is to take away all sensation. Algia means pain. Analgesic means to take away pain. Anesthetic means to take away sensation. So a local anesthetic not only eliminates pain, it takes away all sensation. So with your lidocaine, local anesthetic, you don't feel your tongue. You can't even feel your tongue. It's not like you don't feel pain. You could bite your tongue. You don't even feel you have a tongue. So that's a loss of sensation. It's not just pain. General anesthetic means you have no sensation generally everywhere. That means you're unconscious. Non-narcotic analgesics and NSAIDs. How do they work? So what we're talking about right now is we're talking about aspirin. We're talking about basically Tylenol, acetaminophen. We're talking about Motrin. They all work the same way. They block injured cells from releasing prostaglandins. They block prostaglandins. By blocking prostaglandins, everything that prostaglandins cause to happen, don't happen. On L15, okay, now you should go and memorize every single word on this. No, I'm just kidding. All right, this is my attempt to explain inflammation, but I just want to draw your attention to a couple of things. You may have learned in oral path, in your path class, about the kallikrines and the kinins and the interleukins and all this stuff. I just want to draw your attention in this big mess. Here's where cyclo-oxygenase is, right? Cyclo-oxygenase turns arachidonic acid into prostaglandins. All right? And we said aspirin and other NSAIDs block this enzyme so these prostaglandins aren't formed. What do prostaglandins do? Well, first, there's many prostaglandins, just like there are many interleukins or cytokines released by white blood cells and so on. But anyhow, prostaglandin E2 causes blood vessels to dilate, it increases capillary permeability, stimulates pain fibers, promotes chemotaxis of white blood cells, and contributes to fever. So if you take aspirin, which stops prostaglandins from being released, that should reduce inflammation and fever. Now, do people take drugs like aspirin for fever? Yes, they do. Now, you'll notice that prostaglandin F2 alpha, and you don't have to know it's F2 alpha, I promise. What does that do? That causes uterine cramping, all right? And it also causes airways to constrict in a different part of the body. So when prostaglandins are formed because of inflammation, it can cause uterine cramping. So could people use aspirin or some other NSAID to reduce uterine cramping? Well, the answer is yes, they do. All right? Like Midol and stuff like that. Also, you'll notice that prostaglandin I2 inhibits blood platelets. And on the other hand, thromboxane, which also is formed here, actually stimulates the aggregation of blood platelets. Let me focus on that rather than this one. So in fact, if aspirin prevents the formation of thromboxane, then it would prevent aggregation of blood platelets. Did we learn that aspirin, a little baby aspirin, is taken every day to reduce the blood platelets from attaching to atherosclerotic plaque, triggering a blood clot? So that's because the formation of prostaglandins can lead to this aggregation of blood platelets. Prostaglandins tend to cause inflammation, so it reduces inflammation. That's why aspirin is an NSAID, a non-steroidal anti-inflammatory. Prostaglandins cause uterine contractions. So aspirin and other NSAIDs are beneficial in reducing painful uterine contractions, dysmenorrhea. Prostaglandins can cause blood platelets to aggregate, so aspirin prevents blood platelets from aggregating. It's antiplatelet, and therefore is used to prevent blood clotting. So that's basically how these work. They are used in terms of pain as mild analgesics. So aspirin and Tylenol are good for alleviating mild pain, but not severe pain. And they also reduce fever. They're antipyretics. And then on the next page, M6, this is page M6. And the prototype of this class of drugs is aspirin. And occasionally what we have done for several of these drug classes is we've given you a prototype. A prototype is a classic example of this category of drugs. Epinephrine is a prototype of a sympathomimetic. Atropine is a prototype of a parasympatholytic. Morphine is a prototype of a narcotic analgesics. And aspirin is a prototype of an NSAID, an NSAID. All right, so what does it do? It blocks the synthesis of prostaglandins. And it does that by inhibiting this enzyme called COX, cyclo-oxygenase. It is a COX inhibitor. So as we've explained, I wrote here, prostaglandins, bless you, are chemicals that normally cause blood vessels, capillaries to dilate, leading to erythema. What's erythema? Redness. And prostaglandins increase capillary permeability, leading to localized swelling or edema. Prostaglandins promote activation of leukocytes in injured areas. Prostaglandins activate noxiceptors or nociceptors, and prostaglandins promote blood platelet aggregation. So aspirin stops all of these things from happening because these are caused by prostaglandins, so it stops that. Now, I made a note that aspirin is not totally efficacious or effective in alleviating pain. Why not? Because what activates pain fibers are both prostaglandins and kinins. Do you remember kinins? Mm-hmm. And so aspirin and ibuprofen and these other drugs only stop the production of prostaglandins. They do not stop the production of histamine and kinins and leukotrienes. So it will reduce activation of pain fibers, but not eliminate it because it's not stopping all of them, because the kinins and other chemical mediators are still being released. So what is aspirin and other drugs in this class, NSAID class, used for? They're used to control pain. Analgesic. The root alg means pain. When you put the letters A or AN in front of a word, it means without. So it reduces pain. It doesn't take away all pain, but it will reduce it. It's also used as an antipyretic because since prostaglandins are responsible in part for raising the thermostatic set point in the hypothalamus of your brain, aspirin reduces this raising of your thermostatic set point, reduces fever. Aspirin is a non-steroidal anti-inflammatory drug. Why? Because it reduces the prostaglandin-mediated swelling, redness, and tenderness. So, because of that, aspirin and drugs in this category are commonly used to treat arthritis, rheumatoid arthritis, osteoarthritis, gouty arthritis, spondylitis, soft tissue in athletic injuries, tendinitis, and dysmenorrhea. You don't need to yell at me, but dysmenorrhea. Now, just to remind us of something we've learned previously, we might ask the following question. Well, if somebody has arthritis, which is inflammation in the joints, wouldn't a corticosteroid be even more effective than aspirin? The answer is yes, because it really reduces inflammation more powerfully than aspirin. So why don't they usually use prednisone or other corticosteroids? Why do they give aspirin or Aleve or Motrin? The side effects. Because we said that when you take corticosteroids for any extended period of time, you develop Cushing's syndrome. And so that's pretty severe. So most people don't want to have their whole appearance changed and also have reduced immune response and all that, even though we do have these more powerful anti-inflammatory drugs. On page M7, aspirin is also used, as we wrote at the top, as an anticoagulant. Actually, the way that it reduces blood clotting, as we've said, is it's really an antiplatelet action. And in fact, if somebody needs to reduce the tendency to form blood clots, thromboses, because of a history of heart attacks or strokes and so on, one of the first things they put them on is they'll put them on aspirin. Actually, they usually put them on aspirin if they've got atherosclerosis and elevated cholesterol levels. Once they've had a heart attack or a stroke, then they put them on something more powerful like Plavix or Coumadin. The main adverse effect, the major adverse effect of NSAIDs, aspirin and ibuprofen, is GI irritation. And that's their main adverse effect. I'm not going to go through all these other adverse effects. In case you're wondering, like, do we have to know them then? No. I don't test you on anything I haven't spoken about. On page M8, there are a whole bunch of different brand names for aspirin, the original prototypical drug in this category called NSAIDs, or non-steroidal anti-inflammatory drug. The most famous brand name is Bayer. Why is that? Because Bayer was the original first brand. You may have run into the names Sirin or Ecotrin. These are enterically coated tablets. And what that means is they've got a hard covering on the outside of the aspirin tablet, and that prevents them from being absorbed in the stomach. By preventing them from being absorbed in the stomach, they don't cause gastric irritation. The problem is, then they have to be absorbed across the intestine, and you might recall that weak organic acids like aspirin, acetylsalicylic acid, are poorly absorbed across the intestine. So even though Sirin and Ecotrim, they promote them because they don't cause gastric irritation, they also are not well absorbed. So just because they make something doesn't mean it necessarily works better. There are a whole bunch of other aspirin preparations. You've heard of Anacin and some of these others. Notice that Anacin has aspirin and caffeine. And in fact, a number of these aspirin preparations have caffeine in them. What's the purpose of that? Nobody really knows. We think that the reason why they commonly put caffeine in these aspirin preparations is to reduce the incidence of migraine headaches. But the amount of caffeine they put in these products is actually less than what's in a strong cup of coffee. So you would actually, to whatever extent caffeine might reduce the onset of migraine headaches, you probably have a greater effect taking a strong cup of coffee. Bufferin is basically aspirin with an antacid. And that's why it's called bufferin. It's buffered. Why do they put an antacid? What did I say is the major adverse effect of aspirin and other drugs in this class? Acid, right? Gastric irritation. So they put an antacid in there to reduce gastric irritation. Now keep in mind, you might say, well, like, why are people taking aspirin again? Some people have to take drugs like aspirin every day of their life to control their arthritis. So if you take, if we take aspirin for a few days, we don't develop much gastric irritation. But if somebody's got to take aspirin for 20, 30 years, they're going to tend to develop a lot of gastric irritation. There's you may have heard of cope. That's got aspirin and caffeine, and these are buffers. Magnesium hydroxide and aluminum hydroxide. There's actually the same ingredients that are in Tums and in Maalox. Midol, the original formulation of Midol, they've changed the formulation. The original one had aspirin and caffeine and cinnamedrin, which is a diuretic. And all that they did is they changed it from aspirin to Tylenol, acetaminophen. But they put a little caffeine in, and they put a diuretic to reduce, quote, bloating, to whatever extent it does that. On page M9, on M9, there are a whole bunch of other aspirin-like drugs that are primarily used, this is page M9, primarily used for arthritis. They include, and you can even see from their brand names, choline magnesium trisalicylate, kind of sounds like acetylsalicylate, goes under a brand name Arthropan, Arthro, like for the treatment of arthritis, and Analgesic, and Arthra-G, and so you can see a lot of these are used for arthritis. There are a whole bunch of them. Another one that everybody has heard of that's in this category is ibuprofen. Ibuprofen, this is another non-narcotic analgesic, NSAID, non-steroidal anti-inflammatory drug. We kind of use this whole descriptive category. They are pain relievers that also reduce inflammation, non-steroidal anti-inflammatory. The original brand name of ibuprofen was Motrin, and then it also goes under a whole bunch of other brand names, including Advil. It's used for the same purposes as aspirin, and here's a bunch of other brand names. Other NSAIDs, other non-narcotic, analgesic, non-steroidal anti-inflammatory drugs, there are a whole bunch of these, and in case you're wondering why did they make so many different brands or types of non-narcotic, non-steroidal anti-inflammatory drugs, because they reduce pain. And the most common medications that people take are pain relievers. Everybody's got aches and pains. And so it's just very, very common. All of us in all of our medicine cabinets have Tylenol and Motrin or Advil, Aleve. We've all got it because everybody's got aches and pains. So they sell a lot of them, so there's a lot of different brands. They're all kind of similar. You may have heard of some of these. This is Arutis, maybe you've heard of that. On M10, naproxen goes under the brand name Aleve, and naproxen and anaprox and Midol extended relief. Maybe you've heard of Dapro or Feldine. These are all similar. They only vary in their pharmacokinetics. Pharmacokinetics means their duration of action and how they're metabolized and how they're excreted, but as far as their pharmacodynamics and what they do, they're all the same. Another one that I do want to mention, they have a newer generation, you could call them a second generation of non-narcotic, analgesic, non-steroidal anti-inflammatory drugs. These are called COX-2 inhibitors, and the most famous of them is Celebrex. And the main advantage of a COX-2 inhibitor is that they are supposedly cause less gastric irritation. So these cause less gastric irritation. This is mostly an issue if you have to take them every day for an extended period of time. Let's take a look at page. This, usually the reprints that I have included come from the LexiComp book, but in this particular case, this is actually from the PDR, the Physician's Desk Reference. And I just wanted to show you what it looks like. It's basically the package insert. On the lower left side, here's aspirin. And I just want to draw your attention to what it says, because again, one of the main goals of this class, as I view it, is not that we're memorizing so much, although it probably feels like it. What are the actions of aspirin? So what does it say? Analgesic, what's that mean? Pain reliever. Antipyretic, what's that mean? Reduces fever. Anti-inflammatory, reduces inflammation. And antiplatelet. And it's used for the relief of headache and painful discomfort and fever of colds and flu and sore throats and muscular aches and pains, temporary relief of minor pains of arthritis, rheumatism, bursitis, lumbago, sciatica, toothache, teething pains, and pain following dental procedures, neuralgia, neuritic pain, functional menstrual pain, sleeplessness when caused by minor painful discomfort, and fever accompanying immunizations. All right, so this, no wonder people take it. As far as in the next column to the right, it says adverse reaction. And what's the very first thing it lists under adverse reaction? Gastrointestinal reactions. So that's the main problem that it has, is GI irritation. And it goes through a whole bunch of other stuff. They have aspirin and extra strength aspirin. Just like they have for a lot of these, you'll notice in the right-hand column, it says Bayer maximum strength aspirin. Okay, fine. Look on the next page, and in the middle column, it says Motrin. All right, so what is Motrin? So it says under description of Motrin that it's ibuprofen, all right? And what does it describe Motrin or ibuprofen? It says it's a non-steroidal anti-inflammatory drug. And under clinical pharmacology, at the bottom, so what is Motrin? Is it any different from aspirin? The answer is not really. It's used as an analgesic, as an antipyretic, as a non-steroidal anti-inflammatory. It's basically used for the same purposes as aspirin. They're all basically the same. And as far as adverse effects, the major warning, just on the bottom right, what's the major warning for ibuprofen? GI bleeding. So it's gastric irritation. So they're really all pretty much the same. Back on page M10. So this was in the middle of page M10. And I wanted to mention a couple of other drugs that are related to the NSAIDs, or non-steroidal anti-inflammatory drugs. One of them is allopurinol. Allopurinol is specifically used for gouty arthritis and also to prevent kidney stones. And it's gouty arthritis is a special type of arthritic pain, arthritis, that's actually a biochemical, a metabolic disorder where the person forms high levels of uric acid, and the uric acid accumulates in the joints, irritating the joints. So there's three major categories of arthritis. There's osteoarthritis, rheumatoid arthritis, and gout, or gouty arthritis. Osteoarthritis is due to repeated trauma to joints. So athletes tend to develop osteoarthritis. They've repeatedly injured their elbow or their knees. Rheumatoid arthritis is an autoimmune disease, more common in women than men, and that's where the immune system attacks the joints. And gout, or gouty arthritis, is a metabolic disorder where there's high levels of uric acid formed. So they treat that with allopurinol. Methotrexate is also an anti-inflammatory drug. It is used to treat rheumatoid arthritis. It can also be used as an anti-neoplastic drug for chemotherapy against cancer, and it is an immunosuppressant, and it can have some adverse effects on the mouth. I'm not testing you on this, I'm just mentioning it so that if you have a patient taking these drugs, you look it up and you're able to understand what it does. On page M11, on M11, the Paraminophenols. What the heck is that? And so basically what we have is we have two subgroups of non-narcotic analgesic NSAIDs. There are the salicylates, which include aspirin and Advil and Aleve, and there are the Paraminophenols, which are represented by acetaminophen. So acetaminophen, whose chemical name is N-acetyl-paraminophenol, or APAP. Now you don't have to know that, but I have pointed out to you that if you run across that expression, APAP, it's the chemical name for acetaminophen. And acetaminophen basically works similarly to aspirin. It blocks the synthesis of prostaglandins. Now, Tylenol, or acetaminophen, is primarily used for fever as an antipyretic and as a pain reliever, an analgesic. Here's the main thing I want to address. What are there any advantages of Tylenol over aspirin and ibuprofen? Are there any disadvantages? Are they absolutely identical, or are there any differences? And there are some slight differences. They're slight. So I made a little chart. So what are the advantages of Tylenol or acetaminophen compared to aspirin? What are the disadvantages? The major advantage of Tylenol over aspirin and over ibuprofen and over Aleve is it causes very little GI irritation. That's its major advantage. So when you take aspirin every day, when you take ibuprofen, Advil every day, when you take Aleve every day, they tend to cause gastric irritation. You don't tend to get that with Tylenol. That's its main advantage. Also, there are fewer people allergic to it. There is about 5% of the US population is allergic to aspirin, but there are very few people allergic to Tylenol. So that's another advantage. Also, this may or may not be an advantage. Tylenol tends to not have as powerful effect as an antiplatelet. Therefore, if you don't want the antiplatelet action, you're only taking aspirin or Advil as a pain reliever, then the advantage of Tylenol is that it doesn't cause that antiplatelet, anticoagulant action. On the other hand, if you wanted the antiplatelet action, taking Tylenol doesn't work. So in other words, anybody who needs to go and take, they're trying to reduce their incidence of blood clots, they're told to take an aspirin every day, they're not told to take a Tylenol every day, because Tylenol doesn't work as well in reducing the formation of blood clots. There is a disadvantage. So the major disadvantage of Tylenol compared to aspirin and ibuprofen and Aleve is it has less anti-inflammatory action. So if you need to take it as an anti-inflammatory drug, usually you take aspirin or Advil or Aleve, you don't take Tylenol. Right? If you're using it as a pain reliever or antipyretic to reduce fever, then Tylenol works as well as aspirin. So those are its main advantages or disadvantages. The major adverse effect of Tylenol is liver damage. That's liver damage is the main concern. And again, you don't really have to worry about Tylenol damaging the liver unless you're taking it every day at multiple times a day. What did we say was the major adverse effect of aspirin and ibuprofen and Aleve? Gastric irritation. So all drugs have side effects. So on page M12, under preparations and dosages, if you take an extra strength Tylenol, there's 500 milligrams in each tablet. So if you take 2 tablets, that's actually 1,000 milligrams. Because it's 500 milligrams per tablet. Now, regular strength Tylenol, does anybody actually buy regular strength? I think everybody gets extra strength, right? Regular strength Tylenol is 300 milligrams in each tablet. So if you take 2 tablets, it's 600 milligrams. So extra strength just gives you a little bit more. What is a Tylenol PM? Tylenol PM, anybody taken that? Tylenol PM has diphenhydramine in it. What's diphenhydramine? It's an antihistamine. But what is the major side effect of antihistamines? They make you drowsy. They cause sedation. So they put this antihistamine in Tylenol PM to make you sleepy. So it's got the acetaminophen or Tylenol as a pain reliever, and they put the diphenhydramine in, not necessarily because you have a cold, but to help make you sleep. So that's called Tylenol PM, because at night, PM. So the Midol PMS is acetaminophen, pyrilamine, which is an antihistamine, and pamabrone is a weak diuretic. Now, a product that I did want to draw your attention to that a lot of people find is quite effective is Excedrin. And what Excedrin does, it's a very clever idea, is each tablet, Excedrin, has anybody taken Excedrin? Yeah. Anybody find that it works pretty well? Yeah. Each tablet of Excedrin is 250 milligrams of Tylenol or acetaminophen plus 250 milligrams of aspirin. And the idea is that you're essentially getting 500 milligrams in each tablet of a non-narcotic pain reliever, and yet, because you're only taking 250 milligrams of acetaminophen, what's the major concern about Tylenol? Liver damage. What's the major concern about aspirin? Gastric irritation. So rather than taking, here's really what we're saying, rather than taking, say, 4 tablets of aspirin or 4 tablets of Tylenol, where we start to worry about either liver damage or gastric irritation, you take 2 tablets of Excedrin, which is equivalent in its pain relief of 4 tablets of either Tylenol or aspirin, but because it's using 2 different pain relievers with 2 different adverse effects, you're not getting additive adverse effects. So in other words, it is common to combine 2 different pain relievers together, each with a lower dose. So you get additive benefit, therapeutic benefit in pain relief, but not additive adverse effects, because they have different adverse effects. And so the dosage of each one individually is low, but so you're not don't really have to worry about adverse effects, but you are getting additive therapeutic benefit in pain relief. The purpose of the caffeine, as we said, is to possibly reduce migraines. And in fact, they have what's called Excedrin migraine. Yep?
So I have a stupid question. So that's why they do that with ibuprofen, right? There's some that are prescribed, but then that are like 800 milligrams. As opposed to just taking 4 pills, you're taking 1. And then
that's right. These are called prescription strength, as opposed to over-the-counter strength. And you don't even have to go and get the prescription strength. All you have to do is double or triple the dose of the over-the-counter one. It's the same thing.
But the benefit is just obviously because of the adverse effects.
Well, in the case of prescription strength ibuprofen or Motrin, it is literally 600 or 800 milligrams in each tablet of Motrin. The normal over-the-counter strength is about 250 or 300 milligrams. So you are taking much more. But you could do the same thing on your own, just taking more tablets. Again, for a short term, for a few days, not a problem. When you start to take it for longer term, it tends to cause gastric irritation. So again, a lot of people find that Excedrin is a nice possibility because it's using 2 different pain relievers. The adverse effects of Tylenol and acetaminophen versus aspirin are very different from each other. But you're getting additive therapeutic benefit. Co-Tylenol, many of you have taken when you have a cold. We've spoken of this previously. That is very typical of the over-the-counter cold products. Acetaminophen is an analgesic, a pain reliever. Chlorpheniramine is an antihistamine. And pseudoephedrine, or Sudafed, is a decongestant bronchodilator, a sympathomimetic decongestant bronchodilator. And that's most of the over-the-counter cold products are very much formulated like Tylenol. Page M19. To summarize, the class of drugs that we're speaking about are the non-narcotic analgesic NSAIDs. We divided them into two subgroups, the salicylates, which include acetylsalicylic acid or aspirin. And very similar to aspirin is ibuprofen and naproxen. On the next page, M20, the other category were the paraminophenols. And the paraminophenols include acetaminophen. So these are slightly different than the aspirin group. And we've already told you the advantages and disadvantages of Tylenol or acetaminophen versus aspirin. If you look at the graph at the bottom, you will notice that in terms of pain relief, there's really not much difference between the pain relief provided by Tylenol and the pain relief provided by aspirin. Very, very similar as far as pain relief. Incidentally, you'll notice they compared it with a placebo. So a certain number of people find that just taking a tablet with nothing in it helps alleviate pain. We've talked about that. That's the power of suggestion. If somebody gives you, they've got a white coat and they hand you a pill and they say this will help make you feel better, there are a proportion of people, about 25 to 30%, who are going to say, I really felt better after I took those white tablets that doctor gave me. Incidentally, on the previous page, this is one study that was done. You won't always see the same results. This actually showed that 650 milligrams of aspirin might actually provide more pain relief than even 60 milligrams of codeine, which is a narcotic pain reliever. So non-narcotic pain relievers can be effective, but when you're dealing with more moderate to severe pain, you do have to go to the next group.